Oh, well, thank you very much for that kind introduction, and it's an honor to be here. So I'll be talking about two different topics. The first is something called SBRT, or stereotactic body radiotherapy, a specific type of radiation for prostate cancer. And then the other thing I'll be talking about is androgen deprivation therapy, some high yield topics that come up very frequently in consultations. And so just for the record, here are my disclosures and source of research support. So again, first part, I'll be talking about SBRT, kind of a review of some of the basics of radiation, and then also a high-level kind of overview of SBRT evidence. And then in the second part, I'll be talking about ADT, or androgen deprivation therapy, kind of what the types are, common side effects, and then kind of a review of the benefits and some preview of tools for personalized decision-making. So let's talk about SBRT. First, just to make sure everyone is on the same page, this is the number one question that I'm asked by patients. How does radiation kill cancer? It's intuitive how surgery works. You'd cut out the prostate, but how does radiation do this? And it turns out that any type of cancer is defined by an ability to grow uncontrollably. A cancer cell can divide and divide and divide and grow or proliferate. And part of that is because it acquires mutations in its DNA. And sometimes what happens is that it's not able to repair DNA damage. That's part of the package. It divides so frequently, it can't repair mutations in its DNA. What radiation does is it actually breaks the DNA. So a beam of radiation on a cellular level will break DNA. And that creates a problem for the cancer cell, because if it has broken DNA and it doesn't have DNA repair machinery, when it tries to divide, which is what cancer cells like to do, it will die. So that's how radiation kills cancer. Cancer cells like to divide. You basically damage the DNA. The cancer can't divide without dying unless it's able to repair itself. And so that's the fundamental reason why radiation works on any type of cancer, particularly prostate cancer. Now, for prostate cancer, there are two fundamentally different types of radiations. There's external beam radiotherapy, or EBRT, and SBRT is going to be a form of that. And brachytherapy is a completely different type of radiation, which is implanted radiation. And I'm happy to answer any questions about that, but I'll be focusing on EBRT and specifically SBRT as it compares to other forms of EBRT. Now, in general, when you're being treated with radiation, you're lying on a table, and you can see two different types of machines there on the left. One is an MRI-guided linear accelerator. I'll talk a little bit about that technology. And the other is a CT-guided linear accelerator. But in either case, you're lying on a table, and the radiation is delivered by something called a linear accelerator, which rotates around you and delivers these high-energy X-rays. You don't see anything or feel anything. There's no burning or heating involved. You're not radioactive. But you are getting high-dose radiation. It is a completely non-invasive practice in terms of the delivery of the radiation itself. Now, what are the types of radiation? So radiation has been delivered in the form of multiple daily doses over a certain time period. And the technical term for a daily dose of radiation is a fraction. So we hear about fractionation. Prostate cancer is uniquely sensitive to a higher dose of radiation per day. Different cancers respond differently. Different tissues in the body respond differently to the dose per day, not just the total dose, but the dose per day. And people have leveraged this in prostate cancer to shorten the forms of radiation that are delivered, the courses of radiation that are delivered. And so if you look at that table, we have what's called conventional fractionation, which is the old standard form of radiation, hence the name conventional. 1.8 to 2 gray per day over 39 to 45 treatments, which is about 8 to 9 weeks. Low daily dose per day, essentially, but you're being treated daily for 8 to 9 weeks. Then, first people looked at an intermediate dose, maybe give a slightly higher dose per day, you shorten the radiation of 4 to 5.5 weeks or so. That's moderate hypofractionation. And technically, it's a dose of 2.5 to 3 gray per day over 20 to 28 fractions. And that is a standard of care almost across the globe. It's been studied in numerous randomized trials that have shown its equivalency to the longer course of radiation, and oftentimes is a standard recommendation. Now, you can push the envelope and deliver an even higher dose per day. Technically, anything greater than 5 gray per day is something called ultra hypofractionation. And specifically, SBRT, or stereotactic body radiotherapy, is when you're delivering a pretty high dose, 7.25 to 8 gray per day. And you can do the math, that's up to 4 times the dose of the conventional fractionation per day. but it's only 5 treatments. And typically these are given every other day or so. So actually the numerical dose is less, but since the dose per day is higher and prostate cancer is sensitive to that dose per day, we see similar efficacy, as I'll show you through the course of the trials that I give an overview of. And so, what is IMRT? That's another question patients are always ask. Am I getting IMRT? What's IMRT versus SBRT? So intensity modulated radiotherapy, or IMRT, refers to the use of advanced technologies to deliver the external radiation with high precision. This means different beams, different orientations, and something called fluence is varied in a way that sculpts the dose of radiation to the target, minimizing dose to surrounding structures. You can use IMRT with the long course of radiation, the moderate hypofractionation, or SBRT. That they can all be done with IMRT, and in the modern era, they should be done with IMRT. But oftentimes when people say, oh, IMRT, they're kind of referring to the long course of radiation. But technically, these are separate things, and it's just a type of planning that is used for any type of radiation. So what is SBRT? So stereotactic body radiotherapy, SABR, it's sometimes called stereotactic ablative radiotherapy, is a form of modern radiation treatments in which high doses are delivered over 1 to 5 treatments using advanced techniques. There are many different platforms that can deliver SBRT, and these are sometimes referred to by their brand name. I think the most common is CyberKnife, and that's a tool for delivering SBRT. So the technique is SBRT, the delivery platform is CyberKnife. There's also Novalis TX, TrueBeam, Meridian, which is the MRI-guided device. For full disclosure, we have the bottom 3 there, that Novalis TX, TrueBeam, and Meridian here at UCLA. We don't have a CyberKnife, but I'm very familiar with that and happy to answer questions about that as well. And then one other thing before we get into the kind of the meat of the topic. When anyone is researching prostate cancer, like a patient has a diagnosis of prostate cancer, it can be very overwhelming, as I'm sure many of you know. And you can look online to find research. And it's important to know that there are very different levels of evidence to support treatments, okay? And when we think about kind of the, evidence-based medicine, we can think of this kind of pyramid of evidence that exists to support what we are recommending. And really at the bottom would be something called a case series or an expert opinion. And that's where, okay, I did some treatment to 10 people and I'm going to publish my results. You could find a paper that says someone did something and they did it to 10 people, but that's not high level evidence. And that's sometimes hard to distinguish because you see a published paper, but it's not nearly the same level of evidence as some other things. And so kind of towards the higher end of this pyramid, you have what's called a cohort study, which is that, some institution approves that you're able to treat patients this way. You set out to treat a certain number of patients this way, and you follow them in real time and you collect data and it's rigorously monitored. And then the higher level is an actual trial, and specifically a randomized trial where half the patients get one thing, half the patients get something else, and you can't control that. Oftentimes the doctor doing the treatment isn't the one that's scoring the results, and it's just a much higher level of evidence to prove something. And then at the top is what's called a meta-analysis, where you take a bunch of individual trials and you combine them together. And so I'm going to stick to presenting cohort studies, trials for SBRT, and then for hormone therapy, I'll talk about some meta-analyses. And I just want to be clear that these are high-level evidence, and it's not the same as some of the other things that you might find when you read, but if you look at the details, there's very few patients or poorly conducted studies. These are actually high levels of evidence supporting what I'm going to talk about. So what is the evidence for SBRT? SBRT is considered a standard of care option for prostate cancer in the United States. It's supported by multiple high-level studies, HYPO-RT-PC, PACE-B, these are randomized trials, a UCLA-led consortium study, which is a phase 2 kind of cohort consortium study, and something called a SARP consortium, which is for high-risk prostate cancer, also looking at a consortium kind of cohort study. So let's go over these in some detail. So HYPO-RT-PC was a randomized trial done in Sweden, meaning half the patients got long course radiation, half the patients got what's called ultra hypofractionation, which is a high dose per day. There it was actually over 7 treatments, so it was not technically SBRT, but it's a very similar principle, and they used a very high dose per day over just 7 treatments. This was a 1,200 patient randomized trial. What did it show? If you look at the right there, we see a graph called failure-free survival. That means someone is living and they don't have a recurrence of their prostate cancer, measured typically by PSA. And if we look, we see the red and the blue lines are completely overlapping. I apologize for that. So the red and the blue lines are completely overlapping. So there's no difference, and these are equivalent treatments. So in a large randomized trial, this high dose of radiation per day over just a few sessions was equivalent to the longer course of radiation. Now, they also looked at side effects or toxicity, both in the short term and the long term, and they found no difference in long-term side effects either scored by the physician or with a patient-reported form. And many of you may have seen some of these forms, and I'll show some later. So what does this mean? Well, this provides high-level evidence, 1,200 patients in a randomized trial, that treatments using a very high dose per day have a similar efficacy and long-term toxicity. And one of the most notable things is that this trial was run from 2005 to 2012 or so, and they used old-fashioned planning. Actually, only 20% of these patients had IMRT type planning. A lot was older course radiation. So it's really a fundamental test of some of the assumptions of how the radiation works. And it seemed to pan out. We see 5-year equivalence in terms of effectiveness. Now, there is another study, which is called the PACE-B study, and these are the early results. I'll show some later results in a second, where in the UK, they randomized patients to SBRT proper, so 5 fractions of treatment, similar to what you might be offered in the United States with IMRT planning, against modern long course radiation, which was broken into the 4-week course and the 8-week course, which are what's used standardly in England. And what you're seeing here are the kind of short-term side effects, and they are completely overlapping. So there's no difference in short-term side effects when you compare modern, proper SBRT, so not the Swedish regimen, but this modern SBRT against modern longer course radiation. No difference in side effects. Now, just about 9 months ago, they published 2-year results, so what they would call medium-term results. And here they looked a little bit more closely at what happens in later time points, what we would call subacute time points. And it turns out that actually, depending on the scale that was used to score toxicity, whether they counted giving medications for a problem as a side effect itself or not, you actually got slightly different results. And there was a small signal that there might be slightly more urinary irritation at the 12 to 15-month mark after radiation with the SBRT versus the other forms of radiation. There was a small increase in what we call a grade 2 side effect, or prescribing medications generally for urinary frequency. Seemed to be short term, so it didn't persist, but it was like a flare of symptoms. And we actually see something like that oftentimes with brachytherapy as well. Now, it was noted that this was highly variable from center to center. So this was a big 874 patient trial in the UK. So there were multiple hospitals that were treating patients, and individual hospitals actually had very different rates of side effects. So it raises some questions about whether technique or experience or other things might play a role as well, which we don't have the answer to. They also gave patients forms to fill out to say how bothersome are your urinary and bowel side effects. And interestingly, there was a slight signal towards maybe a little bit more urinary bother in patients that got the SBRT. It wasn't what we call statistically significant. It wasn't a big effect. But interestingly, there was actually less bowel bother with the SBRT. So there's less bowel or rectal irritation, and that was statistically significant. So what does this mean? Well, I think this tells us that there might be some subtle differences. If you look very closely, there may be a little bit more prescription for urinary medications in patients that are getting SBRT, and maybe some subtle worsening on patient-reported forms that's happening really at 1 year and then maybe fading away, but can certainly happen. And there may actually be less bowel side effects with SBRT. So again, it was center dependent, and I think we need some, maybe we'll await the longer term results, which may be available next year, but it's good to note that there may be these subtle differences. What about our group? So we looked at patients in North America, where we've been doing SBRT basically since the year 2000. And we wanted to say, well, we don't have a randomized trial in the United States, but we've treated so many people. So we will, and I see a question in the chat about SpaceOAR. I have a slide on SpaceOAR, so I will get to that and give my thoughts at that time. But basically, in this study, we looked at 2,142 patients that were treated in the US from 2000 to 2012, where we had long-term outcomes. So it was a single-arm study. So it's not a randomized trial. It's what we call a cohort or consortium study, where we took a bunch of different trials, 12 different trials, but a lot of patients, and we wanted to see what happened in the long term. And what we see is a favorable toxicity and efficacy profile. The curve there on the right is biochemical recurrence, so PSA rise that is of a concerning extent for low favorable intermediate risk prostate cancer and unfavorable intermediate risk prostate cancer. And the 7-year recurrence rates were 4.5%, 8.6%, and 14.9% respectively. So pretty good control rates. And this suggests that, modern SBRT is safe and effective. And for the safety piece, what we did is we went through all of the published large trials and we scored the percentage of severe side effects. So not something that requires a medication only, but maybe a procedure is required to fix this. This is that would be a feared side effect of radiation if you need a procedure to fix something. And we looked at genitourinary, which means urinary, basically, toxicity, bladder toxicity, and we looked at bowel toxicity, gastrointestinal, GI toxicity. And we literally plotted the percentage of toxicity just to give a visual comparison. And you can see conventional fractionation, moderate hypofractionation, brachytherapy as a alone, brachytherapy boost, and SBRT at the bottom. And what you can see is SBRT appears pretty favorable here too. Now, again, this is not a comparison, but the long-term 7-year severe toxicity is actually very low in this study with SBRT, whether it's bowel or bladder, and we can quantify it. The 7-year risk is about 2.4% for bladder and urinary issues, and the average time to onset, the median time to onset was about 27 months, so slightly more than 2 years. And for bowel toxicity, 0.4%, a median onset of 31 months. And again, certainly this number with SBRT is low and comparable to other forms of radiation. In fact, some of the higher rates you're seeing are actually with a brachytherapy boost, which is a known issue with that treatment, which is very effective as well. But you can see there may be some more urinary toxicity and maybe even some more bowel toxicity. What about for high-risk prostate cancer? So most of the data of what I've shown is more for low and intermediate risk prostate cancer. What about high-risk prostate cancer? So we did a study looking at this as well. We initiated a trial in 2014 to treat patients with high-risk prostate cancer with SBRT. And we are not the only ones. Other institutions across the world did so. So we decided to pool all our resources together and create what's called a SHARP consortium. We had 344 patients. And an average follow-up of about just under 4 years. And we looked at these early data for this group of patients. It was 7 trials across the world. And what we see is a 4-year biochemical recurrence-free survival rate, meaning patients are living without a recurrence, of 82% overall, which is really good. With hormone therapy, it was up to 87%. I'll talk about hormone therapy a little bit later. But these are very good results for high-risk prostate cancer. And I think this tells us that SBRT is effective for high-risk prostate cancer. Now, there are obviously bigger studies that are being done, and this is early. We're looking to update this later this year with longer-term follow-up. This was published just about 2 years ago, but it's something that we offer as a standard of care. We offer SBRT to patients with high-risk prostate cancer. So let's talk a little bit more about some technical issues. How is SBRT delivered? And here's the anatomy, which I'm sure many of you are familiar with. Bladder on top, prostate kind of below the bladder. There's a tube called the urethra that runs through the center and out, and the rectum is behind the prostate. Now, what's maybe not as obvious or intuitive is that the prostate is actually a moving target. When we're treating the prostate externally, we need to make sure we hit it every time we're delivering radiation. And doing that requires an ability to account for the subtle motions that occur as the bladder expands and contracts, as the rectum expands and contracts, as the pelvic floor might tense, the prostate is moving. We spend a lot of effort trying to understand how much the prostate moves. It's about 3 millimeters front back, 2 millimeters side to side, and 3 millimeters up down in about a 3-minute time frame. So if you're treating the prostate with external radiation, you need to treat not just the prostate, but some margin around the prostate to make sure that wherever it's moving in that time frame, you're hitting it. And so that's this concept of a margin. And because this is high value real estate, there's so many important things close by. That margin means that part of the bladder and the rectum, and maybe even some blood vessels that may be related to sexual function, may need to get dosed with radiation. Okay, so historically, and in many practices currently, the way that we target is with a CT or X-ray guidance. The prostate itself is not easily seen on a CT scan, or I should say, is not seen with great resolution on a CT scan, which is why men who are diagnosed with prostate cancer get MRIs, right, to stage the prostate cancer. Or even sometimes now, if you have a rising PSA, you might actually get an MRI before you get a biopsy. MRI gives a really good picture of the prostate. But historically, it's been unable to combine an MRI with a radiation machine due to some physics issues. And so instead, we've used metal markers to help give a surrogate of the prostate position. You put these metal markers into the prostate, it'll show up on an X-ray or a cone or a CT scan, and you can kind of align or track those markers. It's a way of triangulating the prostate. So in this type of workflow, you have a small outpatient procedure. You put 3 metal markers into the prostate, and when the patient is getting treated, you get a CT scan, make sure the bowel, bladder, rectum look okay, and then you align based off the markers within the prostate. You use X-ray based alignment, and you can even repeat the X-rays during the treatment if you need to try to move things to adjust for prostate motion. The CyberKnife, it does use this approach. Basically, they have paired X-rays, and those X-rays are repeated with a frequency of maybe once every minute, once every 2 minutes, and the linear accelerator can move as the prostate is moving. That's the fundamental technology with a CyberKnife as well. So it's also fiducial guided. Now, there are MRI-guided machines that are on the market now. The ViewRay Meridian device, came out around 2019 or so. And that device does include an MRI within the linear accelerator. So that technical issue kind of has been solved. There are solutions to incorporate an MRI. And so if you have that device, you don't need the fiducial markers because you can actually see the prostate. You have the MRI. You don't need to put the markers in. But the added benefit is actually not just that, it's the overall precision. And here, rather than using indirect X-rays that are showing the metallic markers, you can get an MRI about 4 to 8 times per second. And you can have the machine basically stop delivering radiation if the prostate is moving too much outside a kind of a preset margin. And so we have done CT guided SBRT with X-rays since 2010 at UCLA. And we had used a 4 millimeter margin. And the trials that I mentioned, they typically use a 5 millimeter margin. Sometimes they go a little bit tighter near the rectum, but that's kind of the type of margin we're talking about. With the MRI-guided device, because of the precision, we felt you could reduce the margins to 2 millimeters. So you're treating less tissue. And here's just a video to orient you. This is the spinal column, the sacrum kind of below in the lumbar spine. Here is the bladder, here's the rectum. You can see outlined in yellow a margin around the prostate and seminal vesicle, and here is the prostate and the seminal vesicle in red. Now you can see at the top it says target in. Okay, now I'm going to play this video. You can see there's some motion, and this is the MRI that you get on the terminal. You can see there that the prostate actually moved outside this window because of some tensing of the pelvic floor, some motion, some gas bubble in the rectum. And when that happens, you can see what portion is kind of outside here. You're still within the margin, so things are going okay, but there are points when it may go outside the margin, and then the beam would need to pause. So you can see here, for example, it says target out because part of the anterior portion of the prostate is outside this preset margin. Actually, part of the rectum is inside. So if you have something that's really finely monitoring this, you might be more comfortable having really tight margins without the risk of missing. And so that's the fundamental technology benefit. Does that matter? And so we want to be scientific. And I mentioned to you kind of the levels of evidence. So I decided to run a randomized trial to see if this tight margin is actually helpful, because it is a slower treatment and it's a very expensive machine to use, to purchase. So we did a randomized trial, and from May 2020 to October 2021, if someone was coming to me to get SBRT, I I couldn't just offer them treatment on the MRI-guided machine. It was part of a trial. They had a 50-50 chance of going the standard 4mm margins with the markers or getting on the new machine with a 2mm margin. And what did we see with this trial? It was published earlier this year. We saw a big reduction in side effects. So this is what you're looking at is short-term, moderate grade urinary side effects decreased from 43.4% to 24.4%. That's nearly a 50% reduction. And for bowel toxicity, went from 10.5% to 0% with the MRI guidance. So what is that telling us? The ability to monitor very frequently gave us the confidence of reducing the margins that are traditionally used in external radiation by 50%. We dropped the margin from 4mm to 2mm. That leads to less radiation to the bladder and rectum, and that led to less side effects. So that's become our standard of care approach for someone that can get an MRI-guided treatment. What about SpaceOAR? That had been asked in the chat. So this is another method for reducing toxicity that's been studied, and here's kind of the physics behind it. It's intuitive, but I mentioned this margin concept, and you can see here the before image. Here's the prostate. Here's the rectum. And this is the high dose region. That's referring to the fact that there's a margin. Of course, we would never intentionally treat the rectum, but because the rectum is right there and we need this margin to adequately dose the prostate, part of the high dose region is going to overlap the anterior rectum. And so the idea behind SpaceOAR is that if you inject the substance into the area between the prostate and the rectum, you can create a physical separation that moves the prostate further away from the rectum, and that will pull the high dose region away from the rectum. And that's a matter of physics. Like you think about the radiation like a light bulb, the closer you are to it, the brighter it is. By moving further away, the less bright it is, the less dose there'll be. So that's the physics behind this. So, on some level, that makes intuitive sense. So the question again, has that been studied in a randomized trial? And it has. So there was a trial that looked at using the SpaceOAR. That's the brand name of this, SpaceOAR. And it was in the setting of conventional fractionation. And it was run, many years ago. So SpaceOAR, I think, was FDA approved in 2018. So this is an older trial. But they did find a reduction in late grade 2 rectal toxicity, which is, maybe needing a medication for this, or maybe having some increased bother or frequency. And you can see on the bottom there, grade 2 plus rectal toxicity, control, which is the dark black, and SpaceOAR, which is this, and this is the chance of developing it. With SpaceOAR, it was basically 0%. With the control group, there were some events occurring with time. Now, what's the flip side of this? Well, the flip side is if you look at this, you could say, well, that's still not a super high number. The grade 2 or greater is still not a very high number. And there's not that many patients at 40 months. You can look, this is a number of patients, 27 and 12 months, 27 and 12. So, you are taking a low number and making it lower, but maybe that's not as much of a benefit to a given patient. And that's certainly true, because anytime you put in something, there's a risk of irritation, infection. There could be a severe side effect if it infiltrated into the rectal wall. So you have to put everything into perspective. And I think it's worth discussing with your radiation oncologist. What's the pro con? What is your estimated risk of having a rectal side effect? How much will this truly benefit you? But it has been shown in a trial to reduce long-term toxicity with follow-up. So it's something that's worth discussing. There are patients with clear evidence of cancer growing outside the prostate. So it's called extracapsular extension. If you have that in this posterior area, then we shouldn't do the SpaceOAR because that might dislodge or disrupt the cancer in some way. And those patients were not included on the trial. Okay. Now, there is a newer, I should say, an alternative to SpaceOAR that's on the market that's called Barrigel. It's a very similar. It's just a different component. It's a different formulation for the gel itself. These results with short-term follow-up were published earlier this year as well. It was a randomized trial, and here they looked at the 5.5-week course of radiation, and they showed a reduction in side effects in the short term. So short-term bowel side effects were reduced. You can see here grade 2, 13.8 versus 2.9% with the Barrigel SpaceOAR. So this is Barrigel, and the other one was called SpaceOAR, but fundamentally they're the same. They're very similar, and they're using the same physics concept to try to lower the dose of the rectum. So let's talk a little bit about the radiation side effects. And we can think about this in kind of short-term acute toxicity, within 90 days, and then late side effects. And, we think about these as urinary, bowel, and sexual side effects. And I would say the most, patients are concerned about late side effects. I think acute side effects we want to minimize, of course, but, if we know they'll resolve, we're more worried sometimes about late side effects from the patient perspective. Fatigue is a side effect also of radiation in general to any part of the body, including the prostate. So that happens in the short term as well. So what are the urinary effects? And I like to explain this by actually just using the questionnaire that we give to patients, the International Prostate Symptom Score. The side effects of radiation are essentially a worsening of these different elements. So incomplete emptying, frequency, intermittency, which means pausing and starting during urination, urgency, how difficult is it to postpone urination, weak stream, straining, and getting up at night. Those are the symptoms that we call urinary bother, and those can get worsened by radiation. So if I have someone that's seeing me that has kind of zeros across the board, that might go up to 1 to 2 across the board in the short term. That can be managed potentially with non-steroidal anti-inflammatories like ibuprofen or Advil, urinary medications like tamsulosin to bring that down. But, if someone comes in and they have 4s across the board, they may go up only by 1 point in each element, but that might have a substantial urinary bother, and that patient may not be the best candidate for radiation. So there are people who just have very enlarged prostates, lots of obstructive symptoms, maybe already on medications, whom the acute bother may be very bothersome. Urgency and frequency we could treat with medication as well if needed. Incontinence or leakage is very rare. There can be some situations maybe in which a patient may not be able to get to the restroom in time if they have a lot of urgency, but it would be very rare. We see more maybe a little subtle dribbling or something rather than leakage as a consequence of the radiation. What about bowel effects? So again, we could think of it as like a bother, and there's another questionnaire called the EPIC questionnaire, Expanded Prostate Cancer Index Composite, that has some questions: urgency, increased frequency, losing control, bloody stools, and abdominal pelvic pain. I think these are essentially the elements of bowel bother. I almost never see losing control of stools, but you can see urgency a little bit more frequently, and some loose stools. Diarrhea-like symptoms is, you can treat with an over-the-counter medicine like loperamide or Imodium. If rectal pain occurs, a suppository can be used. And again, we think about baseline issues. Like if someone has inflammatory bowel disease and they already have big problems with each of these elements, maybe this isn't the best treatment option for them, right? But if someone has very little bowel problems, we might expect some increase in these. But ideally, again, they would resolve with time, and that increase may not be overall extremely bothersome. And I think this is well capsulated. Again, I like to go by data. This is high-level data, 874 patients from that PACE-B United Kingdom study, SBRT, and the longer courses of radiation, looking at changes in the first 12 weeks. So this is urinary incontinence, a lower amount. So dipping below 0 means you're having symptoms. And what you see is that there's maybe like a very subtle dip, which is usually, dribbling, that resolves. There's the obstructive symptoms that resolve. There's bowel irritation that resolves. Sexual issues we talk about in a second that resolves, and some energy issues that resolve as well. But the key is you see this peak at the 4-week mark, and it tends to resolve by 12 weeks, okay, from the radiation side effects. Now, what about late side effects? So there is a chance of developing significant side effects. And I showed the data with SBRT. We were looking at 2.4% at 7 years for a grade 3 side effect, and for bowel it was 0.3, but let's call that 1%. So these things can occur, and they can be very bothersome if they occur, a significant severe late side effect of radiation. A subtle side effect like needing a medication like a Flomax or some small change in bowel frequency, those are more common. But you were talking about severe side effects. They can be treated with the procedure, or they could be treated with something called hyperbaric oxygen therapy. And unfortunately, a radiation-induced cancer is a possibility, right? There's a reason that no one else is in the room when you're getting the radiation, right? People don't want to be exposed to radiation because it could cause a cancer. Very often, the risk-benefit favors doing the radiation because the chance of that is very rare, but it's not a 0% chance. What about sexual side effects? Oftentimes the number one concern. Acute side effects are rare unless you're getting hormone therapy, but you could have a low volume of ejaculate. And I've had a couple of patients notice a little bit of blood in ejaculate in the acute setting due to inflammation. But the major long-term side effect is ED, which is also age-related and may occur in about 23% of patients after 2 years, following SBRT. And what is this caused by? With surgery, we think of the nerves being cut. And here's an example of the anatomy. Here's the prostate, and here on MRI, that's the neurovascular bundle. So there's some nerves that run towards the back of the prostate. They kind of loop around and under, and they control erections. So it turns out that we think the nerves themselves are relatively resistant to radiation. But maybe the blood vessels within them, the narrowing of those blood vessels that happens with age and time, that can be accelerated by the radiation. And there's both blood vessels within this neurovascular bundle complex, and then also the internal pudendal artery, which is inferior to or below the prostate, may also be implicated in this. And so we think that radiation-induced ED is related to damage to blood vessels, which means that medication aimed at increasing blood flow may work. It may be therapeutic to give a sildenafil or Viagra or tadalafil or Cialis, but it also may be preventive. And I oftentimes offer a low daily dose of Cialis to my patients to try to maintain blood flow, even if they're not particularly active. This is a daily dose to take to try to maintain and keep the blood vessels open after radiation. Now, the last randomized trial that I'll talk about in this context is the PACE-A trial. And this was just presented at our annual meeting in February of this year. So this is kind of hot off the press data. It has not been published yet. But in the UK, they're very good at running these trials. And they have this trial of surgery, radical prostatectomy versus SBRT for favorable prostate cancer. And they looked at 2-year patient-reported outcomes. And what you can see, urinary incontinence, surgery is the blue, and SBRT is the green. There's a big hit with surgery, but because of leakage. And you can see at 2 years, the pad rate was 46.8%, whereas with SBRT it was 4.5%. Obstructive symptoms actually maybe got a little bit better with surgery, which makes sense because you're cutting out the prostate. So if there's any kind of big prostate causing problems, you're cutting that out. But at 2 years, there was very little difference, and it was back to baseline, more or less, for the radiation patients. If you look at bowel, there was a little hit with SBRT, and there wasn't with surgery, and that's expected. There is bowel irritation with radiation and not with surgery. And sexually, there was a small decline with radiation, going from close to 75% of on this scale to maybe a little bit of around 60%, but much bigger hit with surgery. Again, I think this is because of the nerve issue versus maybe accelerating age-related ED. Now, this hasn't been published yet, right? And to be logically consistent, I'm saying trials are high-level data, but we want to rigorously evaluate a paper. This has not been published in a journal yet. Only been presented. So I would say we can anticipate that, but this is a very solid trial group from the UK. They do a lot of good work, and we have no reason to not trust the initial results they're presenting here. So just keep that in mind. Now, how can we reduce side effects? That's always what we want to do, right? We want to use technology or knowledge to reduce side effects. I already talked about the tighter planning margins. That was the MIRAGE trial, the MRI-guided approach. I'll briefly touch base on radiogenomics and real-time adaptive radiotherapy. So radiogenomics is the idea that patients obviously will probably be differentially sensitive to radiation. One person is not going to respond the same way as another person. Same way with medications, and probably the same way with surgery too, right? Ability to heal after an injury. So this is the concept of radiogenomics. And specifically, our idea is that the high dose per day and the low dose per day are fundamentally different, and the body experiences that differently. So we may be able to predict who may be uniquely at side effects risk that's a little bit higher with the high dose per day or the low dose per day. And so we developed here, and with my collaborator, Dr. Joanne Wiedes, a test. It's a cheek swab test that we believe can identify patients that are at a higher risk of late moderate grade urinary toxicity after SBRT. Now, the key is, of course, this can be detected before you treat somebody. So the way to use this would be if you find that someone is at a high risk of side effects, maybe they don't want to do this treatment, or they want to do some other treatment, or they want to change something. What data do we have? We did publish in 2022 kind of our early work of discovering this signature. And let me walk you through this. So this is probability of no toxicity, and this is time. And so what we have here in blue is predicted low risk of toxicity. So we predict they're not going to have, a high risk of toxicity, and the rate of toxicity was 5%, or 95% had no toxicity. Okay, no significant toxicity. Now, in those that are predicted high risk of toxicity, it's not that 100% had it, but about 55% by around 1,000 days had experienced a moderate grade or worse urinary toxicity. So based on this, we designed a trial called the Garuda trial, which ran for a little less than 2 years. The 200th patient was enrolled in May 2022. And what we did is someone was coming to see me, I would get this test. And then a patient could decide, do they still want to do SBRT or do they want to do something else? And actually, only about 8% of people have the signature that predicts higher consequence with SBRT. So most of the patients on this trial got SBRT, but a handful decided to do another course of treatment. And our idea, what we hope to analyze next year, will be with this carefully kind of selected group of patients that we hopefully kind of didn't include a lot of the patients at high risk of side effects, will we have even lower side effects overall than has ever been reported? So that's kind of what we're looking for with this study. And adaptive radiotherapy, on a day-to-day basis, the size and shape of the prostate, of the bladder and the rectum, and maybe the prostate can vary. And so adaptive radiotherapy is a process wherein we actually take that into account. The patient is on the table and we change the plan. That requires a lot of overhead logistical challenges, but it's something that we're getting to. And we hope actually to open some studies using this new type of radiation later this year. So overall summary, SBRT is a standard of care option for patients with localized prostate cancer for favorable risk patients based on large randomized trials, comparing SBRT to longer courses of radiation for high-risk patients, primarily based on a large cohort study. Early results of a trial comparing SBRT to surgery for favorable patients are also available. MRI-guided SBRT has been shown in a randomized trial to reduce short-term side effects, and a significant effort is underway to reduce side effects even more. And so that's improved delivery, radiogenomics, and adaptive therapy. Okay, so in the next part of this, and I know we have a time limit, so I'll try to go quickly. I'll talk about hormone therapy or androgen deprivation therapy, because I get asked about this all the time. And as Ethan mentioned, I try to do a lot of research, and we've studied this extensively as well. So just going back, castration for prostate cancer is long known to be effective. So it was first described all the way back in 1941 by two doctors, Huggins and Hodges. And actually, Huggins got a Nobel Prize for discoveries regarding hormonal therapy for prostate cancer back in 1966. The original form of hormone therapy, unfortunately, was surgical castration or giving estrogen medications. But as medical science advanced and pharmaceutical science advanced, they've developed medications that are injectable that can work to deprive the body of testosterone in a reversible fashion. That's called medical castration or androgen deprivation therapy, first introduced in 1982. And so that's what ADT is. Hormone therapy is a broad term. ADT is a type of hormone therapy wherein testosterone levels are brought to extremely low levels, and it's really medical castration, but the key is it's reversible. Just as nomenclature, castrate levels of testosterone is less than 50 on most assays, 1.7 nmol per liter if your lab uses that. And 150 is the cutoff for what we call low testosterone or hypogonadism. So we're talking about getting to levels of less than 50 with a medication like this. It's typically given using an injectable gonadotropin-releasing hormone agonist. That's a scientific term. Again, I'm happy to answer questions about it, but we call this medications like Lupron, which I'm sure you've heard of, or Eligard, or goserelin, which is another type of medication that does this. Lupron, which we use most frequently in our clinic, is available in a 1 and 3 month shot, and a 2, 4, 6 months are also available, but maybe have to be ordered. What are the different types of ADT? We have already, I mentioned, kind of leuprolide and goserelin, and the brand names are there. That's an agonist medication. These are depot shots. They're either intramuscular or they're subcutaneous, as they go under the skin. Eligard is subcutaneous, Lupron is intramuscular. They do have a longer time to testosterone recovery than the stated period of ADT. What do I mean? If we give someone 6 months of Lupron, the testosterone is actually going to be suppressed for possibly 9 to 12 months because it takes the body time to recover testosterone after you shut it down completely. It also paradoxically causes a flare of testosterone acutely. So within the first 14 days, testosterone levels actually rise. That's actually not thought to be an issue contemporary, practice, where we are diagnosing patients, thankfully, at lower grade and stage of prostate cancer. But for someone with a big prostate tumor, or if unfortunately they have widespread metastatic disease, we want to avoid that flare maybe. So this is one consideration. And then there are some data suggesting cardiovascular side effects with Lupron. Degarelix or Firmagon is a fundamentally different type of injection. It's a GnRH antagonist. It's a monthly subcutaneous injection, but it has no testosterone flare and has a very rapid onset of dropping testosterone levels. It doesn't wait 14 days, more like 48 hours. And Relugolix or Orgovyx is the newest of these medications. It's an oral medication, an oral version of Firmagon. It has the most rapid return to baseline testosterone, which is obviously the appeal of it. Might have some more frequent diarrhea because it is a pill, but it might have less cardiovascular toxicity. Now, these medications, the ADT, should be contrasted to what's called non-steroidal ARSI, or androgen receptor signaling inhibitors. These are different medications that work at the level of the hormone receptor. They don't per se drop testosterone levels, they block the action of testosterone. And you'll see why I'm making this point in a second. So first generation medications are things like bicalutamide, known as Casodex, and some other related medications, flutamide and nalutamide. Now, there's some data that because these medications don't drop testosterone levels, they may preserve libido. And for that reason, that's a popular choice. And, a lot of people that I see have been started on bicalutamide and they've been told that's better than Lupron because it preserves libido. And I do see that, anecdotally, I do see that there's less libido suppression with these medications. But the drawback is, I'll show in a second, there have been many trials that have shown that Lupron works, right? I mean, for all its side effects, it does improve the efficacy of radiation. The one large trial that was run with bicalutamide or Casodex actually didn't show any benefit. So it almost begs the question, is it why even use it? Unless you're trying to shrink the prostate. If you're not going to go on hormone therapy, the bang for your buck with this medication may not be that great, as opposed to just not doing it. And we, in the metastatic setting, actually, there is an FDA warning that bicalutamide shouldn't be used alone. It has been shown to be less effective than androgen deprivation therapy. So I always just keep that in mind when I see someone that comes in with this medication, do we really want to be on this medication? There are second generation drugs that are very effective. These are oftentimes not used for patients that have localized prostate cancer, which are the majority of patients that I treat, but they are out there. Abiraterone or Zytiga, and then the amide drugs, so apalutamide, enzalutamide, darolutamide. These are newer drugs that are very effective. So not to be confused with Casodex or bicalutamide, these drugs are very effective, but they are oftentimes used in more advanced disease alongside androgen deprivation therapy. So what are the side effects? Decreased bone health, maybe some increased insulin resistance, increased diabetes risk, cardiovascular risks, some sexual dysfunction, gynecomastia or breast tissue development, reduced size of genitals, fatigue, hot flashes, cognitive changes, anemia. Nobody would want to have those side effects, right? And that's why there have been a lot of studies, to try to see who needs it, who doesn't, who needs long-term hormone therapy, who doesn't. And again, at the end, I'll talk about personalized, tools. We hope to get to a time one day where we can really confidently tell someone if they need hormone therapy or not. But what are the benefits and why does it help? So ADT has cytostatic effects. That's the fancy way of saying it stops growth. So, it puts the cancer into hibernation. And prostate cancer gets energy from from testosterone. So dropping testosterone levels will put it in hibernation. It can also cytoreduce the prostate. That means it can shrink it. So if someone has a big prostate, it's causing them symptoms or problems, or is a precluding treatment, you can shrink it with hormone therapy. And finally, I think least appreciated, but maybe one of the most important benefits, is it actually makes the radiation stronger where we're aiming it. So it's not so much that the hormone therapy is needed because we think there might be disease we don't see outside the prostate. It's that it actually helps make the radiation more effective where we're aiming it. Even if the cancer hasn't spread, there are cases in which we want to use hormone therapy for a short amount of time with the radiation. And that has to do with the ability of hormone therapy to limit cancer-related DNA repair. And if you remember in the very beginning, I said that the way radiation kills cancer is by damaging DNA, and the cancer can't repair it and dies off. Prostate cancer sometimes can repair itself using hormone-mediated pathways, and so dropping hormone therapy hormone levels will actually increase the effect of the radiation. So what are the recommendations? Intermediate risk, it's about 4 to 6 months of hormone therapy if you're using standard radiation. High risk, about 18 to 36 months with standard radiation. And if you're using extremely high dose radiation, maybe 12 to 36 months. And in terms of the timing of the hormone therapy with the radiation, there's a bunch of different terms. Neoadjuvant is the portion of hormone therapy before radiation. Adjuvant is the portion of hormone therapy after the radiation. And concurrent is the part of the hormone therapy during the radiation. So what are the data supporting the use of this? And at least 19 trials have evaluated ADT with or without, excuse me, that should say radiation with or without ADT for localized prostate cancer. And there are 3 fundamental questions: adding ADT to radiation alone, and most trials look at adding 4 to 6 months of hormone therapy, prolonging the part of hormone therapy that's before the radiation, and then prolonging the part of hormone therapy that's after the radiation. And so we established something called a MARCAP consortium, me being myself and Dr. Dan Spratt, who's in your neck of the woods. He's in Cleveland University Hospital. Actually, that's probably very far from Cincinnati. Forgive me, I'm from Los Angeles, but he's in your state. And it's a global effort to try to synchronize patient data from multiple randomized trials that have been run, so we can answer some questions using all of the patients who have given their time to research, right, to these different trials. And so we published this last year. What's the benefit of adding hormone therapy? You can see for all comers, all patients, there is a survival benefit. You can see on the right here, a 10-year overall survival benefit going from 57% without hormone therapy to 65% with hormone therapy. And if you look at something else like, the chance of living without metastases, that's also better, 52% to 61%. And another way to think of this is number needed to treat. What is that? That means how many men do you have to give hormone therapy to prevent a distant metastasis in one man at 10 years? And that number is 18 for intermediate risk disease and 8.4 for high risk disease. And so in oncology, we think of these as good numbers, meaning like that's a pretty effective intervention. There are many cancers in which there's no therapy that would ever have that big of an impact. And so as much as the hormone therapy has a lot of bad side effects, it does work in terms of improving the effectiveness of treatment. However, extending the part of hormone therapy before radiation, so if you're going to give someone 4 to 6 months and then you say, I'm just going to give a couple extra months before, that's been studied in several trials, and actually that doesn't have any benefit. So that should be discouraged unless there's some other reason, like you're going on a trip or something and you need to be on hormone therapy to prevent the cancer from growing. But it's as a standard practice, it's not beneficial to front load and extend hormone therapy. To backload hormone therapy, adjuvant prolongation is beneficial. And in fact, the magnitude of the benefit is similar to the benefit of adding hormone therapy alone. So going from, say, 18 months to, going from 4 to 6 months to, say, 18 to 36 months has a big benefit of 8% metastasis-free survival, and excuse me, 6% overall survival. And you can look at the numbers needed to treat, 16.1 for intermediate risk and 10.4 for high risk. Now, we typically only do this in patients with high-risk prostate cancer because we're talking about compounding benefits who are adding hormone therapy and then prolonging it. But it does have an effect as well. Now, how long should that last? If you have a high-risk prostate cancer, how long should you be on hormone therapy? And again, for someone getting standard dose radiation, I should say EBRT, which includes 78 gray of radiation, the standard is 18 to 36 months. And for extremely dose escalated radiation with a brachytherapy boost, it's about 12 to 36 months. Our group looked at this as well. We have data from 16 high volume centers across the world that have used different durations, and we tried to see what's the best duration to use. And what you're looking at is a graph. Essentially, the bottom here means the biggest benefit in metastasis-free survival. For patients getting 74 to 78 gray of radiation, it looked like the sweet spot was actually 26 months. Whereas for patients getting very high doses of radiation, the sweet spot might be shorter, 12 months. This is not a randomized trial. So to be logically consistent again with our kind of, my slide about the pyramid of evidence, this is going to be kind of a retrospective study. But it certainly is an interesting signal. And it's going to be many years till we have a randomized trial that shows this. But it's something to consider. Maybe when you're giving very, very high doses of radiation, you can shorten the hormone therapy a little bit. And the final point on this is the concept of absolute versus relative risk. And I always try to explain this to my patients. So all these studies that we did show that in general, a population of patients with prostate cancer gets a benefit from adding hormone therapy. And that benefit we can quantify at 10 years, it reduces the risk of metastasis by 40%. But for an individual patient, maybe that doesn't matter as much. What matters is what's my risk of metastasis, not what the population risk is, what's my risk. And here, I kind of just made this graph of 7 different patients, A through G, that have a different risk of metastasis to begin with. And for patient A, their risk of metastasis is 2.5%. So if you drop that by 40%, that's really a benefit of only about 1%. So for many people, that's not worth it, right? Like, I don't want to go under the hormone therapy if I'm only going to get a 1% actual benefit. Whereas patient G, they have a much higher baseline risk, close to 30% chance of metastasis. For them, there's a 12% reduction in the chance of metastasis. And I think for a lot of people, any number above like 8% is like a big effect, right? And this person may be very eager to do the hormone therapy because of the big benefit that it provides. So there's an absolute benefit and a relative benefit. And we're trying to get better at predicting a person's absolute risk so that we can have these nuanced conversations. What about sequencing? So the sequencing of hormone therapy, I showed that front loading or extending the beginning of the hormone therapy is not particularly helpful, and extending it afterwards is helpful. But what if you're only getting 4 to 6 months, right? You have intermediate risk prostate cancer, you're only getting 4 to 6 months. Then that's not as relevant. The question is, how do you sequence the 4 to 6 months? And different groups, different trial groups have used different types of hormone therapy sequencing. In the US, it's typically been neoadjuvant concurrent. In Europe, it's been concurrent adjuvant, and in Australia and Canada, it's been neoadjuvant. So good thing is we have enough data to try to answer a question like this through that consortium. And we published this earlier this year. This is a complicated figure, so I'll just draw your attention to this here, which is, we're looking at concurrent adjuvant versus neoadjuvant concurrent, meaning you starting the hormone therapy when you start radiation, and most of it is afterwards, or you're starting it before and during, and there is some of it in your system afterwards, but it's not an intentional portion afterwards. And what we see is the 10-year benefit of concurrent adjuvant sequencing versus neoadjuvant concurrent sequencing is pretty significant. The metastasis-free survival benefit is 8%, overall survival benefit is 6%, and the recurrence benefit is about 14%. So when treating the prostate only, you're not treating lymph nodes as a patient with intermediate risk prostate cancer getting 4 to 6 months of hormone therapy, I think this publication suggests that we should be backloading most of the hormone therapy. Now, I don't want anyone to be stressed out about this. You know, if you happen to have started hormone therapy a month before your radiation, that's okay. All right. You can always add a little bit more, or probably most of it is still going to be backloaded. But we should, and there may actually even be a benefit to having 2 months before, 2 months during, 2 months after. You know, we didn't look at the combination. We're just looking at one strategy versus another. But my practice, I don't see a need to front load the hormone therapy in the vast majority of patients. And the final kind of trial I'll talk about is intensified hormone therapy in selected patients with high-risk prostate cancer, a very recent publication, again, out of the UK, where they looked at patients getting 3 years of first-generation hormone therapy, adding some intensified drugs. Here it was abiraterone. And a lot of people think of this as a trial of patients with metastatic prostate cancer, but actually this particular study did include 60% of patients that had non-metastatic prostate cancer. They just had to have 2 of the 3 high-risk features, T3, T4, Gleason 8 to 10, or PSA 40 or higher. And in these patients, there was a big benefit to adding intensified hormone therapy, metastasis-free survival 82% versus 69%. Now, last bit, and I know it's a long presentation, is looking at personalized medicine. So Decipher test, a lot of you have probably heard of this. This is a genomic classifier. And what it is they're sending the prostate specimen, whether it's a biopsy or the prostatectomy, to a lab in San Diego and doing a test to look at the gene expression. And I only focus on these details as a way of explaining this and how I explain it. It's useful to think about how this was developed. So these are men that were treated with surgery 1987 to 2001 at the Mayo Clinic. They had men that had metastasis after their surgery at some point, and then they have men that either never recurred or that had just a PSA rise but didn't develop a metastasis. And they want to see what is the genetic difference in these patients, in their tumor, not the patients themselves, but the tumor, versus the patients that never develop metastasis. That's what the Decipher was originally designed to do. That's what it was validated as, and it started in that space. It has since been extended and shown to maybe be useful in the upfront risk prognostication. So someone asking, what is my risk of metastasis or dying of prostate cancer? So still taking something that was derived from patients treated with surgery over 2 decades ago, but maybe applying it kind of to a modern population. And what I'm showing you here is on top, it's the risk of metastasis and the risk of death of prostate cancer for NCCN high and unfavorable intermediate risk prostate cancer and low and favorable intermediate risk prostate cancer. And those curves are very overlapping. But when you look at the Decipher score and whether someone is kind of genetically high risk tumor or genetically low risk tumor, you get a better separation of these curves. The people that are genetically have a genetically non-aggressive tumor actually truly have a very low risk of metastasis at any point, whereas the people with a genetically aggressive tumor are much higher risk of metastasis. And this has been studied in different contexts. What this is showing you is 42 studies, 30,000 patients, definitive and post-operative setting, looking at different endpoints like adverse path, means cancer growing outside the prostate, positive margin, seminal vesicle invasion. BCR is biochemical recurrence, metastasis is developing metastasis, and PCSM is prostate cancer specific mortality. Looking for an effect greater than 1 means it's a real effect. Like this actually predicts for this outcome in a significant way. It appears to do that across most of these studies. And importantly, if you compare it against standard of care, which is this gray line here, it does a better job of predicting each of these outcomes compared to just standard of care. Standard of care plus Decipher does the best job. So this dark blue is the highest bar, means it has the best ability to predict whether someone is going to experience metastasis at some point. But the caveat is this is based, this original signature was based off of men treated many years ago. And we have better tools and better things these days than we did before. So I think the take home is that it does give a good prediction of aggressiveness, but the actual number that you might see for death from prostate cancer is probably lower today than it was, 2 decades ago, thankfully. So just, keep that in mind as well. And the final thing is this emerging, artificial intelligence concept that people may have seen or heard about from a company called Artera. It's the multimodal artificial intelligence prostate prognostic model. It's a handful, but essentially the idea is that you can take some of these clinical variables, and there's actually 6 clinical variables, and then you can look at the slides, the actual biopsy slides, and maybe there is data in the slides that the human eye can't detect. We give a Gleason score, but maybe there's a subtle differences that the human eye is not able to detect, but maybe a machine can detect through something called machine learning. So what they did is they took these 6 variables, they took digital pathology slides, they took an average of 2 slides per patient, and they came up with this model to see whether that might do a better job of predicting things. And here you see it's comparing against NCCN guidelines. Blue is this new model, and this is the NCCN guidelines. It outperforms it uniformly for all these endpoints: distant metastasis, biochemical failure, prostate cancer-specific survival, and overall survival, all better predicted with this model. It's not perfect. By no means is it perfect. There's still things that it's not able to predict, but it does a better job than our existing methods. Okay, and this is using data from the pathology slide. And very recently, literally 1 month ago, an interesting publication that suggested that it might not just prognosticate a risk, but actually show whether hormone therapy is beneficial. And that would be kind of a first ever thing, to be able to show if hormone therapy is beneficial. And here, distant metastasis, prostate cancer specific mortality. For everybody, if you look at everybody, there is a benefit. Adding hormone therapy is a benefit. And this is a famous trial where you added short-term hormone therapy. But in some patients that the model predicts there's no benefit, there actually was no benefit. Going backwards in this trial, there was no benefit to adding hormone therapy if the model predicted no benefit. Whereas if there was a predicted benefit, there was actually a bigger than expected benefit in these patients. So I think, this is a kind of looking in the future. Maybe we'll have these tools so that if someone comes and they have a diagnosis, we can say, what is your risk of, having a cure, essentially? What is your risk of a metastasis? And what is your response to hormone therapy? And that may be able to help us refine these discussions. Whereas right now, we have to say high-risk prostate cancer, you get a benefit from hormone therapy, being at like a long duration, and intermediate risk prostate cancer, you get a benefit from a short duration of hormone therapy. So overall summary for this portion, adding hormone therapy to radiation has a benefit in nearly all patients. The magnitude does vary. We have first-generation agents like bicalutamide that don't have the same level of evidence and may not actually improve outcomes. When delivering long-term hormone therapy, it's best to prolong the portion given afterwards. When delivering short-term hormone therapy, also may be best to have the portion of hormone therapy given afterwards. For selected patients, with high-risk prostate cancer, abiraterone, a second-generation agent, might significantly improve survival. And we have emerging tools like Decipher and Artera AI that may help refine the personalization of these decisions. And I know that was a little bit long, but I'll end there with some time, maybe about 15 minutes, I think, for questions.